very good afternoon to everybody. It is indeed a pleasure to invite you all for this inaugural iIGF deficiency program, which is a unique program which we have developed basically, which incorporates each and every aspect of IGF deficiency. A lot of issues in terms of evaluation, in terms of assessment and management, and many of these problems are actually not really catered for in terms of appropriate manner. So what we have done is that over the next 2 hours or so, we'll focus about the various aspects of IGF deficiency, right starting from pathophysiology, which is in itself a complicated issue, to take over in terms of when to think of the conditions, which will be discussed by Dr. Neha. Then we'll take forward with regards to the evaluation, the etiology, going forward in terms of the role of IGF-1 and BP3, which Dr. Sajali will take over. Then we'll have the growth hormone stimulation and dynamic test. Dr. Riddhi will take over. Then subsequently we'll talk about in terms of management, in terms of the conventional GH therapy, the long-acting GH therapy, which Dr. Chetan will be talking about. Subsequent to that, we'll talk about pubertal modulation, the role of GnRH analogs, and the role of aromatase inhibitors, Dr. Pratik, and finally IGF deficiency. So this is going to be overall a compact program of 2.5 hours, in which we'll cover a lot of these things, starting from basic pathophysiology to the different aspects, covering different the whole aspects and gamut of this disorder. So now we've already discussed a lot about pathophysiology. We will now move forward to more clinical parameters in terms of pointers and criteria. At this point, I'd like to also thank Pfizer India, who are our sponsors for this program, who have made this possible. And before we move forward, we will now like to invite Dr. Neha, who will talk about the pointers and criteria of IGF deficiency. And Dr. Neha has been our fellow in Regency CDER from 2017 to 19, and she is now basically coming in terms of, she's now working as a senior resident at the Himalayan Institute of Medical Sciences, and she will talk about this very interesting topic in terms of IGF-1 deficiency pointers and criteria. Over to you, Neha.
Hello.
Yeah, Neha, start.
Yeah, thanks for the kind invitation, sir. So after a thorough discussion regarding the physiology and pathophysiology about the growth hormone IGF-1 axis, it would be pretty easier to understand the pointers and criteria of the associated conditions. So as we have already discussed that apart from the role of growth hormone and IGF-1 on the growth, it also has effect on multiple other organ systems. So starting from the physiology again, just to touch in a brief, secretion of growth hormone from the pituitary under the influence of growth hormone releasing hormone acts on the growth hormone receptor present on the liver, which causes the secretion of IGF-1. This IGF-1 causes an inhibitory effect on the production of growth hormone via two pathways. First is via the inhibition of somatotrophs directly, second is via the production of somatostatin, which in turn has a negative feedback on the pituitary somatotrophs. The IGF-1 produced circulates in the blood in two forms, namely the unbound form and the bound form. The bound form is mainly bound to IGF binding protein, among which IGF binding protein 3 constitutes the major form. Now, this IGF-1 plays a role in neural development. So the clinical implication of this effect is that newborns who are born with IGF-1 deficiency or resistant, these newborns, in addition to having short length at birth, also have neurodevelopmental delay, while newborns who would be born with growth hormone deficiency will be neurologically sound, since there would also be some growth hormone independent IGF production. Secondly, this IGF-1 plays a role in musculoskeletal development and growth, which accounts for the psychomotor delay seen in the patients of IGF-1 deficiency. Thirdly, this IGF-1 has a role in cardiovascular protection, and it also has a role in glomerular function of the nephrons. Together, these both hormones contribute to the maintenance of blood pressure, and deficiency in IGF-1 is important in production of metabolic syndrome, of which hypertension is one of the components. The most important role of IGF-1 is in the intrauterine growth of the fetus. Since we have read in the previous discussion that intrauterine growth is independent of growth hormone and is completely regulated by IGF production. So any deficiency or resistance in IGF action will lead to intrauterine growth restriction. So IGF-1 not only in the intrauterine period but throughout life has important physiological roles. As it can be seen from the graph that circulating IGF-1 levels are maximum during the childhood and the pubertal period, and they gradually decline as the humans age. And this decline in IGF-1 contributes to many of the morbidities which are associated with aging. So during the early infancy period, this IGF plays a role in providing genetic stability by contributing to growth in neurogenesis, synaptogenesis in the central nervous system, and in the genitalia development. So as sir already highlighted, that presence of micropenis or undescended testis should alert one towards this IGF-1 deficiency or resistance. During the young period or the peripubertal period, this IGF plays a role in enhancing the bone accrual, in anabolizing effects, and in various proliferative mechanisms. While during the middle age period, it helps in the metabolic control by controlling the lipid and glucose metabolism, and it also aids in hepatic and cardioprotection. While during the elderly life, it plays a role in telomere shortening and contributes to the various comorbidity that are found during the aging process. So after going through the physiology and the role of IGF-1 at different stage of life, we now move on to the conditions which are associated with IGF-1 deficiency. So IGF-1 deficiency during the intrauterine period will lead to intrauterine growth retardation or restriction. It may present with Laron syndrome, and later these children or these humans are at risk of developing metabolic syndrome. The 5 major components of metabolic syndrome being insulin resistance, abdominal adiposity or visceral obesity, hypertension, dyslipidemia in the form of high triglycerides, and low HDL cholesterol. Because of the role in liver, heart, and kidney, this IGF-1 deficiency has been found to play a role in chronic liver disease, in cardiovascular diseases such as ischemic heart stroke, and also in other comorbidities. So since we are talking about growth in this talk, we focus on intrauterine growth restriction, Laron syndrome, and metabolic syndrome. So coming on to intrauterine growth, which is regulated by 3 important parameters, which are the maternal factors, placental factors, and the fetal factors. During the early weeks of gestation, when fetal growth hormone production is not present, placental growth hormone comes into picture, and which causes an increase in the circulating maternal serum IGF-1 level. These IGF-1 plays an important role in the development and growth of placenta. Any inhibition in the formation action of IGF-1 will lead to placental dysfunction, which will inhibit the movement of nutrients from the mother to the fetus, leading to intrauterine growth restriction. As already said, these newborns would be neurologically impaired because IGF-1 plays a role in the neuronal development as well. And also there would be a risk of metabolic syndrome in these children later in life. Metabolic syndrome, apart from the 5 main components described earlier, are also associated with PCOS, non-alcoholic steatohepatitis, and risk of stroke and cardiovascular disease in later life, and thus early identification and prevention of metabolic syndromes becomes important. This arises due to compensatory hyperinsulinism secondary to low IGF-1 level in the body, and replacement of recombinant human IGF-1 has been shown to enhance insulin sensitivity and reverse the components of metabolic syndrome. Third, IGF deficiency has also been shown to play a role in the pathophysiology of Laron syndrome. So talking about normal physiology, the production of growth hormone from pituitary gland acts on the growth hormone receptors on liver to produce IGF-1, and this IGF-1, by acting on IGF-1 receptor, plays a role in the growth, proliferation of cell, and inhibition of apoptosis. It also gives a negative feedback inhibition to the pituitary to stop the production of growth hormone. While in the pathology of Laron syndrome, there is the production of growth hormone from pituitary, but either due to a mutation in the growth hormone receptor or defective IGF-1 gene, there is decreased production of IGF-1, which causes a decreased feedback mechanism and more of growth hormone is produced. So Laron syndrome is characterized by high growth hormone level with low IGF-1 and low IGF-BP3. Studies have shown that patients or newborns born with this condition have slightly short birth length, but birth weight is shown to be within normal limits. While those with growth hormone deficiency have an unaffected birth length since intrauterine growth is independent of growth hormone action. Because of overlapping features of Laron syndrome and those of growth hormone deficiency, it is important to identify and differentiate these patients from growth hormone deficiency because of the expense involved in the diagnosis and management of these patients. So apart from severe short stature, Laron syndrome is characterized by a typical facies, as Sir already highlighted in the previous presentation, which is characterized by frontal bossing, sparsity of hair, glue sclera, saddle-shaped nose or hypoplastic nasal bridge, and maxillary hypoplasia. We also find crowding of teeth because of mandibular hypoplasia in these patients. The bone age or the skeletal maturation is delayed, and because of the importance of IGF-1 in musculoskeletal development, these children often have psychomotor delay. Summarizing the differences between growth hormone deficiency and growth hormone insufficiency, at birth, those with growth hormone deficiency usually have unaffected birth length, but those with growth hormone insufficiency are born with restricted growth. Facies of growth hormone deficient patients is more like a doll-like chubby facies, cherubic facies, while those with growth hormone insufficiency have a coarse facies in the form of frontal bossing and mid-face hypoplasia. Basal growth hormone, although is not recommended nowadays, but in growth hormone deficiency, if somebody is still doing, it has no role. While in growth hormone insufficiency, one may find growth hormone levels, basal growth hormone levels, well above the normal range. IGF-1 generation test, which will be discussed in subsequent presentation, is measurement of basal IGF-1 level and 5 days after giving daily growth hormone at 25 mics per kg per day. If there is a rise by more than 15, it goes in favor of growth hormone deficiency, while if the patient fails to produce a rise of more than 15, it goes more in favor of growth hormone insufficiency. So just to summarize, it is very important to differentiate patients from growth hormone deficiency since it plays a role in management, and these patients of IGF-1 deficiency are characterized by severe short stature with normal screening investigations and normal growth hormone levels. Presence of micropenis, undescended testis, cholestasis should alert the treating physician. And since IGF-1 has a role in neurodevelopment, presence of psychomotor delay should alert the treating physician towards the possibility of IGF-1 deficiency. Apart from the clinical pointers, there is an important role of doing IGF-1 assays and growth hormone, which will be discussed in subsequent class because there is quite a lot of confusion regarding the standards available for the current Indian population. Thank you.